Uh, I would like to start by apologizing that I only have 2 years of experience in this condition. Um, I don't know if they can find another speaker with more, but I mean, that's just me. The other thing is that when you have a new topic that you're giving a talk, what would you do? Would you ask your colleagues for the talk? Well, it's just a similar talk, so you can then improve on it. But I asked for one of the talks, but I couldn't use any slide because things have changed so much that I had to start from scratch, and the information you see here, it changes so much that all the references are likely going to be 2021, 2022. I have no conflicts of interest, and the objectives are first to see whether there's any connection between COVID and the development of PH, COVID and the development of chronic thromboembolic disease, how COVID impacts patients with PH, and then how development of RV dysfunction in patients with COVID worsens their prognosis. This is the trends in the numbers of the COVID cases and hospitalizations. The hospitalizations are in yellow, and you see on the right side at about now 2,500. This is an average of weekly hospitalizations. 96 million cases, and about 1 million patients died with COVID. This is the curve of the daily trends in numbers. As you can see, there are a lot of peaks and valleys, and some of the studies I'm going to show you, they may have occurred at different points during this curve, and also in this one. So everything has to be adjusted by the mortality of that time, the presence or not of vaccinations, the presence or not of treatments, and then the experience gained throughout the month in treating the disease. There are two conditions in pulmonary hypertension that are inflammatory infectious diseases that may lead to PH, such as HIV and schistosomiasis. The question is whether COVID could potentially lead to the development of PH. And I know it's probably early, only 2 years since this was first happened. But there may be some interesting associations between the two to think about. For example, we have hypoxic vasoconstriction during the disease in some of the patients. We have a cytokine storm, we have mitochondrial dysfunction, oxidative stress with DNA damage. All those things occur in pulmonary arterial hypertension. We also have thrombosis that could potentially lead to chronic thromboembolic disease. The virus, as you know, enters through the ACE2 receptor. The ACE2 receptor is diminished, the number in patients with PH. So that could potentially be a protected factor, but no one knows. And then this ACE2, they kind of degrade angiotensin 2, and that could potentially, if the receptor is blocked, there could be a factor that protective of pH. But if they have an excess of ACE2 activation, angiotensin will increase, and the vasoconstriction, inflammation, fibrosis associated with that. So the MPH and COVID. So with COVID, we have microthrombi with different degrees of organization and inflammation. The endothelial cells also have disruption of intercellular junctions. There's some swelling. They lost contact with the basal membrane, and they have this proliferation called intussusceptive proliferation, which is a way that the vessels grow, which is abnormal. And then there's problems with pericytes, and the pericytes have been associated also with pulmonary hypertension. So they have an intimate connection with the endothelium. And they can also be involved in the cytokine storm. The smooth muscle cells may undergo dedifferentiation and proliferation. The fibroblasts also may have proliferation, fibrin deposition, all those things that could potentially be linked to the development of PH. These patients with COVID, they have a very interesting factor, which is this loss of regulation of hypoxemic vasoconstriction. Normally, when you have hypoxemia, you have vasoconstriction. But these patients tend to lose that. And as you can see here, where you have the opacities of the pneumonia process, you lose your perfusion. But around that area where you should have hypoxemia and vasoconstriction, you have an increase in the number of vessels here on perfusion. And this is something kind of unique to the condition with dilated, as you can see here, dilated vessels proximal to the lung opacities. Some people have compared the hemodynamics of patients with ARDS before COVID and patients with ARDS due to COVID. And obviously, this is a historical data. But what they have seen is that the pulmonary wedge pressure appears to be higher in patients with ARDS and COVID. The cardiac index lower, but the PVR also lower because of these lack of vasoconstriction as a leading theory for it. The presence of hypoxemia with the release of all these factors can certainly lead to vascular injury associated with inflammation and complement activation. As I pointed before, patients with PH have downregulated ACE2 receptors, so maybe as they have less receptors, the virus can get into the cell less and maybe a potentially protective effect. The nitric oxide has anti-inflammatory, anti-proliferative, antiplatelet properties. So if you were to give PDE5 inhibitors and enhance the nitric oxide, you could potentially have a protective effect. Inhaled nitric oxide improves oxygenation RV after load, which is a potential benefit. Prostacyclins also have antiproliferative and cytoprotective properties. So if you give treatment that you give for PH to these patients, that also may be protective. And endothelin-1 may aggravate lung injury by activation of this necroptic pathway and fibroblast proliferation. So if you were to give endothelin receptor antagonists, it may be potentially beneficial. So the patients with PH that are treated, you're working on all these three pathways and that they could potentially have a protective effect. Although this has not been proven, this is kind of the initial theories why, and as you will see in a minute, PH patients didn't appear to get the infection as frequently, but more recent data is just similar. This is one of the first reports that we had from New York Langone on the patients with PH that acquired COVID, and those patients initially did pretty bad with 45% mortality, 64% require ICU. With time and different other investigations, like in this case, PH centers in the US, 32 centers that received this survey, and they were able to put together 13 patients. Of those 13 patients with pulmonary hypertension that developed COVID, only one died. So patients were doing better, but take into account this is a year after the first study. There's another survey that was sent out now to 47 centers and different around the world, and pneumonia was the most frequent presentation of patients with PH that developed COVID, then fever, and then you see there 17% require ICU admission, and the mortality was 19%. The mortality is higher than expected for the places that are represented here. This is from the French registry. They have more than 7,000 patients. Of those, at the time of the study, 211 developed COVID, 2.7%, which they say it's similar to the general population. And of those patients, some of them were managed in the outpatient setting. No one died of those. And some required hospitalizations, in this case about 60%. Those who were hospitalized, and mortality was high. And it was related to, obviously, older age, but male gender. And then they start associating male gender. As you see, male gender is also associated with worse outcomes when you have pulmonary arterial hypertension. But here on COVID too, male gender, cardiopulmonary and renal disease, and the severity of the PH. And if you were anticoagulated at baseline, your risk was lower. This is just the graph showing the same thing with age, male gender, and renal disease and other comorbidities as a risk factor. I'm going to skip this. It's interesting that once we start having COVID, most of the visits, or a good number of visits, end up being now in a virtual setting. So there's a lot of papers describing how the management of patients with PH shifted from more inpatient to more on the virtual setting, with decrease in referrals, as you see here, decrease in PTEs and BPAs, since patients were potentially evaluated less, the ORs were occupied with other, or hospitals was occupied with other conditions. So the number of procedures during that time dropped. Same thing was seen in Italy here, where you see more than 70% reduction in number of procedures and reduction in hospitalizations for PH and number of newly patients diagnosed. So this data can be seen in two ways. They say, hey, so we are seeing patients less and we're doing less studies and then there's less hospitalizations, but one of the explanations is that the beds were occupied by other patients and these individuals were managed more in the outpatient setting. Patients with PH need to receive vaccination for COVID, and the reasons for what they do not receive, this is a study from Poland, are mostly, I'm afraid, of the side effects. And as you know, the patients that got the vaccine, the side effects, the most common one was pain, fever, fatigue, but nothing really serious. This is an important slide of the management of COVID therapies in patients with PH because of a lot of interactions with Paxlovid. All the other ones, you're safe. But Paxlovid, it's a great medication because of the reduction in hospitalizations and mortality, but being this inhibitor of CYP3A4 increases the levels of sildenafil and tadalafil. So you have to consider modification of therapy, stopping it while you're receiving this therapy. May increase the concentration of ambrisentan, although no action is kind of recommended with ambrisentan. With macitentan, the risk is X, so you need to avoid that combination because of the increased concentration. And also consider therapy modification when you combine with bosentan and riociguat. With Celexipac, no action is needed, and anything which is treprostinil, ibuprofen, or iloprost, you are safe. Oh, and then there is another issue with the calcium channel blockers that also the levels can increase. So those things you have to take into account when you start Paxlovid on these patients. If you have ARDS due to COVID and you develop RV dysfunction, you will do poorly. What is interesting about these is that people have found slightly differences between the indices that we use to define RV dysfunction and the outcome. Because it appears in COVID is not only just the longitudinal contraction that gets affected, but also the global mobility. So they consider the fraction area change of the RV as a better marker of the function of the right ventricle and to be used in prognostication. Longitudinal strain also is good and is associated with outcomes. There are meta-analyses that show the same thing, RV dysfunction has an odds ratio for mortality of 3.3. If you are admitted in the ICU and you have RV dysfunction, RV dilation, or PE, the chances of mortality are going up. And as you see here, big differences from 50% to 25%, depending on the associated factor. If you have COVID and you develop PE, you'll do worse. And the prevalence will depend on where you are admitted. This meta-analysis here show a prevalence of 14% VTE in patients that were hospitalized, and higher incidence in the ICU, 23 versus 9%. And this is in spite of thromboprophylaxis. So you have to have a high index of suspicion, particularly in those with lack of parenchymal lung disease. So this is an important slide. If you're at home, less chances of VTE. If you're hospitalized, it increases, and if you go to the ICU, it increases even more. And the PE can be microthrombi in red, it could be in situ in gray, or true PE in blue, around 14% as we discussed. It's interesting to know that even though a lot of patients got admitted, as I showed you before, and some of them develop PE, that the incidence of chronic thromboembolic pulmonary hypertension has not yet increased. And there's this study that showed that the referrals at least didn't significantly increase, but there's obviously a lot of biases in this, but it doesn't appear to be an explosion of cases of chronic thromboembolic pulmonary hypertension related to all these episodes of PEs the patients had. If you see there, conservatively, 3% of hospitalized patients with COVID had PE, and maybe 1% will develop chronic thromboembolic disease. So based on a super large population that got hospitalized, then there should be more cases, but maybe we'll see later, or maybe it's a different mechanism of disease, and maybe as a patient recovers from COVID, it rapidly dissolves those clots and they do not go into chronic state. So in conclusions, these findings are continuously changing because all the literature you read, then it's going to be a new strain, and then whatever you know, it's going to be a little different. Vaccination also affects some of the studies that about prognostication, survival, because it's obviously most of the data I showed is pre-vaccination era or just starting into vaccination. Management changes or new therapies for COVID, better ways of ventilating patients, so all that has to be taken into account. No clear association between COVID and the development of PH as of yet. Unclear if the PH therapies provide any protection for acquiring COVID infection. We need time to see whether those PEs that patients developed while hospitalized may turn up to be an increase in chronic thromboembolic disease. Take into account that Paxlovid has massive amount of interactions with all the PH medications, so review that carefully. And RV dysfunction associated with worse survival in the ICU in patients with COVID ARDS. And that would be it.